morning to all of you, and this is Dr. Praveen Chandra, and along with me is Dr. Siddharth.
Hi everyone. Our patient is a 59-year-old gentleman with a past history of coronary artery disease, had a PTCA done in 2013 to LAD and D1 bifurcation. At that time, he presented with angina and he underwent this procedure 2013 a long back. And he was doing well till like 7 days back when he had an episode of unstable angina and he was diagnosed as inferior posterior wall MI in the hospital where he was thrombolized and was stabilized for next 24 hours, and then he was presented to us with the this type of angiography. So angiography was done on day before yesterday, which revealed patent stents in LAD and diagonal with a very good flow in both the stents and minimal restenosis. Next shoot. So this is the long LAD stent with the diagonal stent at the bifurcation, which is very well flowing. The LAD distally has an approximate 90% distal lesion. So this is the aleocranial view, which is also showing a good flow in the stents with a minimal restenosis. Circ is having a small, although it is a very small vessel and having a 80% stenosis in the mid part. And the main lesion was in RCA. Next please. So this was the RCA lesion. In between, at the midpoint, there is ruptured plaque with a thrombus inside, and the distal PD is also having some thrombus. PLV is also having mid approximate 70 to 80% disease. So our plan was to again anticoagulate for next 1 to 2 days, and then we'll plan for. So this is the RCA today. So distal PD has a good flow now without any thrombus, and PLV has small disease, which is already mentioned in the previous angio, and there is a ruptured plaque in the mid RCA. So we have wired the RCA in the until the PLV distally. Next plan will be discussed by Dr. Chandra sir.
As you already mentioned, that this right coronary artery is the culprit today. He has been a thrombolized patient, acute coronary syndrome. So we have given in heparin and dual antiplatelets already loaded. Do a IVUS now. Can we do an IVUS? So this is a volcano. The advantage of using a volcano in this is that it is very quick and don't have to do any major preparations. Although people do discuss about the depth, basically it's since it is a 20 megahertz versus so you can see that we are not able to cross the this IVUS catheter at this point, which means that this lesion, which was not appearing that much on the angio, but on this angiogram today, but probably it is significant, and we see that there is some calcium. So we'll pull back, and yes, there is calcium here. Can you do just a quick check? Yeah, where we are. Yeah. So this is very clear that this is a significant lesion out there, and disease there. And this is the tightest part, you see. And there is some ulcerative lesion here, mixed heterogeneous plaques out there. But interestingly, the distal lesion is quite significant. So we have to dilate it with a 2 millimeter balloon. Give me a 2 millimeter balloon. Go up 2, 4, 6, 8, 10, 12. Okay. So we have gone up to 12 atmospheres and the lesion seems to be done. Go up more. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Okay, deflate. The vessel looks like a 2 millimeter vessel. And we might have to do a cutting balloon with it too, because there is a fibrocalcifix area. So give me a cutting with 2. Check, please. Okay, go up, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is 10 atmospheres with this Wolverine, and we'll keep it for about 10 seconds. Pressure, please. Show the pressure always. Okay, deflate. I will check a little bit. Check. Air is there.
in that guide.
Check. Check करिए. Okay, so we'll pull it a little bit back and then go up more. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. So we are doing a further dilatation of the proximal segment of the RCA PLV, and you can see that it is a 2 into going up to 12 atmospheres. And so this is our dominant strategy when we are treating small vessels, good as much as plaque modification. Certainly we cannot do a rota here. Would you do a rota here? No, never, because it's so distal. What would you do? Nothing else. This is the best strategy in this situation. Deflate, please. I'll also check this now. The length of this lesion, certainly not big. Okay, just store it. We don't need to dilate with this balloon because the lumen is already okay. And there we are. Okay. So you see that this lesion is well treated now. So now which drug-eluting balloon are we going to take? So typically now since the sirolimus-eluting balloons are available, so should we take a 20 or a 25? That's the question. Take a shot, please. Shot. This looks very nice. I think 25 will be better. Give me a 25. So this is a 25 millimeter, and this is a 2.25, 25, and this is the solution which comes from Med-Alliance, and now it is a J&J stent, J&J balloon. So there's a drug-eluting balloon which has, the release kinetics are slightly different because the drug is, in some kind of globules what they have made, and the balloon is wrapped in a proper way. Check, please. Okay, I can go a little bit further. Okay. Okay, check, please. Yeah, fine. Go up. 1, 2, 3, 4. Yeah, 5. So the nominal is 6, and with the 2.25, and at 5 atmospheres it is 2.23, and the size looks quite good. The vessel ID was about 2.2 to 2.25, so we are fine. I don't think we need to go any further in terms of pressure. And how long will we keep? Generally, we keep for about 2 minutes if the patient is tolerating. So we are presently how many? 1 minute. So this is a sirolimus eluting 2.25, 25. It's already 1 minute. Okay. Fine. And then we will slowly deflate it at the end of maybe 2 minutes. But if he is tolerating, 2 minutes is the usual time which we give. Okay. Deflate, please. So it is 2 minutes now. Now take a shoot, please. Okay. So you can see that the distal lesion is very well done. There is no residual, and there is no dissection. Everything looks good. And this is a 25 millimeter balloon up there. To measure the size of the stent we have to take, and you can see that we can easily take maybe a 30. It's better to take a little longer one.
Yeah, 30 to 34.
38. 38. Give me a 38, please. Yeah, give me a 338. So there are plaques all over, but certainly we'll match the luminal diameter and the distal segment, and then proximally we can go ahead little higher with a 3.5 if required. Yeah. So we are taking a 3.338. 338. So this is a 338. Okay. And this is Zines Alpine. Zines Alpine 338. Okay. Check, please. In this area it looks okay. I think we are fine. Okay. Check, please. Yeah, it looks
Just-
very good actually. Okay, so I think we have to dilate a little more. So whether to take a 3 millimeter balloon or a 3.5, I will IVUS it again, because sometimes the vessels are in spasm. So in those situations, we have to give some nitro in between. And have we given some nitro? Give some nitro. Give some nitro. So there is no major issue, and slow flow is not there. Although it was a ulcerated plaque acute coronary syndrome, we were expecting that could be that there will be some slow flow, but the flow is absolutely TIMI3. Okay, so I can see on the live this thing. Okay, go up, please. 1, 2, 3, 4. So there is the live stent boost. Again, this is a system which comes with this, volcano system.
4.
Go up to how much?
4.
4, 5, 6, 7, 8, 9, 10. Deflate. So it looks like we have covered the stent edge. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. I think the stent is now very well expanded. Deflate, please. The dilatation looks quite okay. 20. Okay. Deflate. Okay. So we are just at the edge. I'll go up here. Go up. 2, 4, 6, 8, 9, 10, 12, 14. Okay. 16. Deflate. So the proximal edge is done. I'll go a little bit inside. Okay. 16. 16, please. 18. Okay. Okay, fine. So we are done. Deflate, please. This is fine. The distal vessel also looks very good. There is no major dissection anywhere, and there is no flow related issues. And I think, we are almost done. So we can check in the other view also. RAO, please. RAO, plain RAO. Yeah. Take a shot, please. This looks nice. And there is a TIMI3 flow all over. And I think the branches are also well preserved. There is no issue with the branches. Both the RV branches are okay. Fine. Okay.
Yes.
Yeah. Should we do a final IVUS? We can. I mean, quickly. It doesn't take too much time. So we should not try to cut short things. Do completely, because this is a very big artery and we need to respect it completely. Show, please. Okay. Yeah. Okay. So pull back now. Yeah, now it is a very well expanded stent. You can see full apposition, good MSAs, and proximally also looks excellent. Okay. So no dissections pre and post, and both at the distal and the proximal edges. So we are done. Okay. So I'll take this RCA catheter out, and we'll go to the left system now. The left system we had stented several years back, and all the stents are doing fine. But he has some distal disease in the LAD segment, which I'm going to show you. So give me a left guiding catheter. Yeah. And this was a bifurcation stent we did. So which year was angioplasty done for you?
2013.
2013.
13.
So this was 10 years back. Okay.
We have discussed this in the history.
Okay. 10 years back.
Yeah.
So when the stents are bifurcation stenting was
Yes,
done.
bifurcation stent.
Yeah. So the stent is flowing nicely, but just distal to the stent, there is a disease which you can see. And epicranial, please. This from the proximal stent and into this RO, please. Little bit RO. Yeah, that's better. Okay. So just distal to that, and it is a reasonable length of segment. So there could be some discussion whether to leave it or just do it, since it is just after the stent. Although the stent was done 10 years back, it's fully endothelialized. Still, I will say that if we are able to do something, it will improve the outcome for this patient. Right. So we are taking the same 2 millimeter balloon first. 2 millimeter?
Yes, 212.
212. And this is a mini track from Abbott. And it's a mini track or an NC track? NC track. So it's an NC track. And hopefully it will cross. I mean, we will eventually do it with a same Wolverine 2 millimeters, but with such tight lesions, especially if the Wolverine has been used in the other lesion, it won't cross. Okay, check please. Oh, 1, 2, 3, 4, 5, 6, 7, 8. Deflate. So this is a 15?
10, 12.
12. Okay, give me a
Cutting ready.
this is Wolverine. So I'm taking a Wolverine now, which is same 2 into 15.
Yes.
Okay, very good. And after this, we will do the IVUS to see whether we are treated the lesion well, and then it will be followed by, if everything is okay, a drug-eluting balloon. Because so distal, putting another stent may not be a great idea, unless until we are pushed to do that. Okay. We go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. That's nice. 12. So this is a 12 atmospheres, Wolverine 2 into 15. Go up a little bit more. 13. Okay, that's good. So in small vessels, and especially if we are planning a DEB, better to atherectomize as much as possible. Deflate. Okay. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. 12. 14. Okay. Keep it. Okay. Deflate. Okay. Check, please. This looks very nice, actually. So I think I have nothing more to do. So we checked in 2 views. Everything is okay. We can stop. So with this, I think we can stop here. Thank you very much.